Good evening, friends online. I'm Dr. Wang Ming from the Thoracic Surgery Department of Shenzhen University General Hospital. Thank you for your continued support and encouragement to Thoracic Surgery Network. Today is our column Connection, Surgical Explanation Live Issue 12. I am very fortunate to invite Professor Fang Weimin from Fujian Cancer Hospital. Tell us about double port esophageal cancer, inflatable mediastinoscopy plus single-hole laparoscopy around the umbilical cord, surgical video of posterior sternal approach. The highlight of the surgery was the nudity of the bilateral recurrent laryngeal nerves. Retrosternal tunnel looking straight. Let me briefly introduce Professor Fang Weimin. Professor Fang is from Fujian Cancer Hospital, Deputy Director of Administration of Second Disease Area of Thoracic Surgery, Chief Physician Master Tutor, Deputy Chairperson of Mediastinal Tumor Special Committee of Fujian Anti-Cancer Association, Member of Esophageal Cancer Committee of Fujian Anti-Cancer Association, Lung Cancer Committee Member of Fujian Anti-Cancer Association, Thoracic Surgery Committee Member of Fujian Medical Association. There are also many academic part-time jobs. The interactive guest is Lu Xiui, Director of General Thoracic Surgery, the first affiliated hospital of Zhejiang University. Welcome to interact in the live stream and WeChat group. Ask questions and provide valuable feedback. Please introduce Director Lu Xiui. Okay, thank you very much, Director Fang. Give us a chance to learn today. Then Director Fang operates here. Inflatable mediastinal mirror included laparoscopy with a single hole around the umbilical cord. Retrosternal tunnel. Created a very perfect minimally invasive system. Then look forward to us tonight. Everyone can gain something. Then thank you, Director Fang. Then Director Fang, let's start. Thank you to Professor Wang Ming and Professor Lu for their introductions. Thank you, Professor Wang Ming, for providing such a platform. I'm also a big fan of their platform. I often watch their videos in it. I'm very happy to have the opportunity today. Let me introduce to you our work in the past year or two. The way esophageal cancer is operated on. As Professor Lu just said, I now have an inflatable mediastinal mirror and a single-port laparoscopy around the umbilical cord, and this way of looking directly at the poststernal tunnel. At present, I think it is a combination that I am quite satisfied with, because this way allows the patient to be minimally invasive. In addition, it is more beautiful to finish the single hole around the umbilical cord. There are almost no scars on the abdomen. It's just that the belly button got a little bigger. And looking directly at the sternum makes surgery safe. It is particularly suitable for hospitals at the grassroots level to develop, and these three parts can exist independently. Each has its own benefits. It doesn't have to be combined. It can be carried out alone. Then let's start introducing my PPT directly. Okay. Thank you for your attention. It's just like I said. This PPT is mainly divided into three parts. One is an inflatable mediastinal mirror. There's also a one-hole laparoscope on the abdomen around the umbilical cord and looking directly into the posterior sternal tunnel. Then I used to do single hole. I used to do single holes in the chest part. From 18 years to now, nearly 600 single-hole surgeries have been performed. It's been an inflatable mediastinal mirror since last year. Because all of China in making single holes adds up. Less than 10 people. Professor Yuan Yung was the first to start. Last month there was a consensus. The cleaning strength is about the same as that porous one. Then the pain will be lighter. That's about it. From the end of last year to this year, I started touching the longitudinal inflatable mediastinal mirror. Because it used to be mainly a problem of collection and procurement. Because there is no dual stage, you can't start. I used to do some peeling and dragging with an ultrasonic knife sporadically. It's still quite dangerous if you really want to go deeper. Not without ligature. The inflatable mediastinal mirror started at the end of 24 years. I haven't done much so far. About 40 cases were done. Mainly these 2 months and last month. My patients have had inflatable mediastinoscopes for the past 2 or 3 months. I'll have a chance to talk more about how to do it later. The single hole around the umbilical cord only started in March this year. It has not been wound around the umbilical cord before. Is to do a single hole. The single hole in the abdomen is made on the umbilical cord and the 3 cm in the middle. Change it to around the umbilical cord at the back because they have abdominal surgery. There are more single holes around the umbilical cord. See you later when they do some. I don't think it's too difficult. It's just a matter of going up and down. Another advantage is that the pain will be lighter and beautiful. There are now more than 100 cases. Usually it's not a big problem. The learning curve is still rather short. The retrosternal approach was developed last year and is now. Tutors carry out more. Professor Sun Yuhua of Shanghai Cancer Hospital recommended me to do it. When you're done, keep doing it. Taste the sweetness because it is very safe. And now Japan does the retrosternal path than the regular one. The esophageal bed pathway is a little bit higher. 30%. Then these 3 surgeries for esophageal cancer on our side. Many are borrowed. Including the inflatable mediastinal mirror, they are all borrowed from our neighbor Japan. So I'm going to start talking about the inflatable mediastinal mirror, which is divided into 3 parts. Our inflatable mediastinal mirror single hole and the back of the sternum. Inflatable mediastinal mirror. We are in a vertical position. Just lie on your back and lean back a little bit. Then head a little to the right. The surgical incision we chose was the left neck. About 3 cm inside the sternocleidomastoid muscle of the left neck. When some patients have particularly large lymph nodes, we also sometimes do a via from the neck. Then a horizontal incision will be chosen. Because we sometimes have to open on the right. My side is if there is a clear transfer. If there is a big fusion, I'll do it from the neck first. If not, or preventive cleaning. I didn't do it. Just a diagonal incision in the left neck. That incision protective cover. They all use this multi-channel. There are 4 channels. Transcervical mediastinoscopy. I think rumbling is the hardest. Left throat return is the easiest. It's 3 difficulties. Free esophagus is generally fine. If the esophagus is not very serious, it will invade. No, foreign aggression is particularly serious. Just say it is within 3. Generally free is not a problem. Including the one we've done before. Not a big problem. The hardest part, I think, is the chart. The lymph nodes are harder. The left throat is relatively simple. The right throat is also difficult to reverse. You can talk about it later. Because it's cramped. Some of the subcarinal lymph nodes will fuse. Especially at the tip of the bulge. Sometimes it's a little more difficult. Normally, put the ligature on the top one. The exhaust hook is placed below. Then the smoke exhaust hook can block it a little bit. And then about ligature. It has a revealing effect. There is also a dissociation effect. There is also a cutting effect. Use these 3 functions together. Just a little bit better. But for those bulges that are particularly hard and particularly difficult, it's actually quite difficult. We used to do open surgery. You can do one of these things normally. It's all difficult. What does start if fused? Both are difficult. It's the same story. In fact, the rate of lymph node metastasis is not high. Then let's take a look at the right throat return. 12 lymph nodes are more difficult and challenging. Because a lot of doctors like to do it from the neck. If there is a neck problem, there is a neck problem. One more incision. One more surgery, one more pathway. Sometimes it's a little more troublesome. There is also sweeping from the neck to the bottom of the recurrent laryngeal nerve. So the oblique span of the recurrent laryngeal nerve will also have certain difficulties there. Then we according to our respective situation. If the lymph nodes are above the recurrent laryngeal nerve, they must come from the neck. If it's below, it can be on both sides together. The trick is to expose the recurrent laryngeal nerve. We do the same with conventional thoracoscopes. Usually these lymph nodes below the recurrent laryngeal nerve. The twin nodes are actually the lymph nodes around the esophagus. We look at it on CT. It's actually one side of the wall next to the right recurrent laryngeal nerve. One wall is next to the esophagus. So we were able to expose the recurrent laryngeal nerve. It frees the lymphatic tissue underneath it. This cleaning strength is enough. It's the vagus nerve, which is the recurrent laryngeal nerve. The trick is to try not to break the mediastinal pleura. If it breaks, it will shrink, and the right recurrent laryngeal nerve and the cartilage of the right trachea. It's actually above the cartilage. So he got very close. If you pick the cartilage, he will directly follow the recurrent laryngeal nerve. We usually carry the membrane cloth first. Separate the cartilage from the nerves. Let the nerves down a bit. You're going to pick the cartilage up at the beginning. Then the nerves and cartilage are in there. You can't get away. It's better to be able to see the subclavian artery. It is safer to drift in this direction. Usually what can hold open is not a nerve that can be burned. And then of course, if you can find the vagus nerve, reverse to the recurrent laryngeal nerve. Then it can be exposed to the inferior thyroid artery. The hypothyroid looks like this. The left recurrent laryngeal nerve. It's relatively simple. Under our inflatable mediastinal mirror. Lymph node dissection of the left recurrent laryngeal nerve. It cleans better than a conventional thoracoscopy of this kind. Because of the recurrent laryngeal nerve, it relies more on the neck. There are some lymph nodes that run to the front of the windpipe. Whether it's a robot or a cavity mirror. From the right chest, this is the blind spot. You can't do it. I often say robots do this surgery from the right chest. It's clearing the lymph nodes to the ceiling. But because there is a problem with its path. No matter through the left chest, through the right chest, there is a problem with the path of his surgery. That's because I didn't know that the mediastinum could do this before. I don't know how strong the cleaning is. So it wasn't launched before. Start passing through the left chest and then pass through the right chest. Certainly a revolution. Then through the mediastinum. Another second revolution. It basically has no blind spots in cleaning. Especially the lymph nodes next to the left laryngeal gyrus. You can't clean it through your right chest. Through the right chest in front of the trachea. Part of it he can't clean. There is also a 112-year. There is no way to clean the left chest through the right chest. So the scope of cleaning by the inflatable mediastinal mirror. A little wider than the regular one. What's more, his requirements for low lung function are not high. Like pneumoconiosis or very old people with poor lung function. If you have surgery, it's basically like doing a stomach operation. So we go one step further, and it broadens the indications. I'm very emotional. We've done a lifetime of thoracic surgery for esophageal cancer. Last time there was a big touch. Just one patient with poor lung function. Then I have to have surgery and I can't do it. In March this year, my patient got bigger after the new assistance. There is no way to ask Professor Hu Yang from Huaxi to do the surgery later. It really touched me. The same doctor who does esophageal cancer. If he can do it, I can't do it. So I've been working hard on this for a few months. We come to the second part of the PPT. Because we can still chat about that video later. The second part of the PowerPoint presentation is. By the way, there are a few small videos here. Some small problems to share with you. I usually watch videos to see how well others are doing. Then we will also encounter some problems. Take it out and show it to everyone. This is a time when it goes from the abdomen to the top. Ready to remove a lymph node. The result is bleeding. I wanted to shoot it with a gun. I dare not because of poor exposure from the abdominal cavity to the top. What if the exposure is not good? I wanted to turn to the shoulder and go in through the neck. This is the neck, and the position just now is the shoulder, so it's pretty short. It's going up the diaphragmatic hole. Bleeding from the aort vein. I wanted to try it with a gun, but I didn't dare. It's easier to wrap it around the neck at the back. If you see the bleeding point, clip it with a continuous hair titanium clip. Burn it down. This is a bleeding video. I was going to open my chest after stuffing the gauze. Try it from the neck in the back. I didn't expect the neck to be relatively simple. Exposing it from the abdomen up is actually quite difficult because I do single hole. No suspension, nothing. It's more difficult. Then it works from the neck. Stop the bleeding and stop it. This is a video of an injury to a thoracic duct. Normally, it will not damage the thoracic duct because the thoracic duct is not there, in the space between our esophagus. Put this thoracic duct and esophagus that day, it's too far gone. As a result, when it drifted under the strange vein arch, made a break. Just clip up the break with a continuous hair titanium clip. The gap between the thoracic duct and the membrane anatomy of our esophagus is not together. But sometimes it drifts too deep. He swam the thoracic duct away. After breaking the upper thoracic duct, the thoracic duct is with the esophagus. A break in the back. It doesn't matter if it's broken. We use 2 continuous hair titanium clips and then we burn it. It's dealt with. There is one below, also thoracic duct injury. After finishing the abdomen, found a bunch of chylus in the neck. Go back and look for the aortic arch. Because there are some thoracic ducts, it is mutated. Some are small. There's some variation on this side of the aortic arch. We'll deal with the breach later. Clip off the trunk here. Just clip off the break later. So these aren't too bad. And we sometimes break the pleura. Because the mediastinal pleura swings more severely. The right pleura I did recently is basically open, including top and bottom. In fact, it opens from the bow down. This pleural swing in the mediastinum would be much better. Next we open the mediastinal pleura. After entering the chest cavity, it's like returning to a familiar environment. These are more confident, and that is to say, clean up the rumble. There is a reference on the right side of the lymph node to be more confident. Here are a few small videos. Tell everyone about the second part of the PPT. The second part is about the single hole around the umbilical cord. Before that, most people think about doing laparoscopy, doing minimally invasive surgery. It doesn't hurt too much. Then most of them punch 5 holes. We used to observe holes like this. 2 holes on the left, 2 holes on the right. And then when you're done, cut a knife in the middle. Pull the whole stomach out and hit the tubular stomach. Why would you do that? Because the tubular stomach is in the abdominal cavity. You dare not hit it. I'm afraid the length of the hit is not enough. That's a problem. Secondly, in the abdominal cavity, almost everyone does a little bit of embedding. You make the esophageal bed for fear that the nail will leak out. Which blood vessel does it hook to? Esophagotracheal leakage, etc. after hooking to the membrane. And if you want to pull the tubular stomach smoothly to the neck, most of them are assisted by hand. So you have to make a little bit bigger than your hand. Hand in. So the final result is like this. That doesn't make sense. If you want to open the incision, why didn't you open it earlier? Not many people do hole reduction work. And that's what most doctors do. People have different opinions. So many doctors simply do open surgery. This is the current situation in the country. Later, we changed the abdominal cavity to a single hole from the previous year. At that time, there were quite a few single holes in abdominal surgery. We refer to them at that time because I didn't have much experience. I don't know how to triple the arrow and the umbilical cord. 3 cm on the umbilical cord, do it first. At that time, it was actually a single hole plus 1. Because pure single hole is actually quite difficult. It will take longer. Because there was no nasal feeding tube. So add 1 to the single hole. This is a nasal feeding tube. I'll try to say it up later. See if it gets better. Our main idea is still this. Under single hole endoscopy. It's hard to do the closer you are to us. The further the easier. Open surgery is the opposite. The splenic fossa is the hardest. It's easier up front. So we had the splenic fossa. The fundus of the stomach is below, and then the right part of the omentum is pulled out of the abdominal cavity to do it. And it was sort of an idea. There is also a video of me at that time on the internet, and we started doing lots of workshops like this. Then by this year, it will be changed to a single hole around the umbilical cord. Also studying abdominal surgery. But we don't put drains anymore. This plus 1 can also be subtracted, but sometimes there are more surgeries and time constraints. There is still a single hole plus 1. He looks better after surgery. A single hole around the umbilical cord has one advantage. It's the blood vessel on the right side of the omentum. It can be done under our endoscope. Because think about it, our anatomical location will probably be at the umbilical position. If you do it upside down on top, you have a hard time getting the incision under the umbilical cord. All the autopsy stuff just got farther away. Now we don't have nasal feeding tubes. There will be a single hole video later. Let's talk slowly. Then the choice of our incision. It's usually a half circle around the umbilical cord. What if the patient is particularly obese? The abdominal wall is particularly thick. The half circle can be slightly out. Even sometimes if that stomach can't be pulled out, you can add a little more distance, no problem. Half a circle of the navel is enough for the thin one. Then add 1, usually on the horizontal line, the midline of the clavicle or the opposite position of the nipple. Just poke another mouth. Then move on to the third part of the PPT. Look directly at the establishment of the tunnel behind the sternum. Because a lot of doctors are doing retrosternal. Remnants of surgery were found in this group of patients who required postoperative radiotherapy. We'll do the posterior sternum. There is also a colon belt that will be done behind the sternum. There is also a small intestinal belt, which is also done behind the sternum. Most people think it's safer behind the sternum, because in case of small intestine necrosis or large intestine necrosis, it is easy to remove, at least not dead. If you die in the esophageal bed in the chest cavity, it will be more difficult to deal with. But it's actually logically the same. Then since you are like this, the tubular stomach behind the sternum also becomes safe. Not very good. Why do I emphasize looking directly behind the sternum? Most doctors believe that the posterior sternal approach a bit further than a traditional esophageal bed. Actually, that's not true. Many people have measured it. We have also done research in this area. Right now there are a lot of treat reconstructions to test. Many articles suggest that the back of the sternum is about 1 centimeter or 2 short. Of course, there are also some articles that think it is longer, because many articles used to measure on corpses. The living volume is different. My own experience is that after the sternum, there are always surprises. It doesn't seem to be long enough. As a result, there are more when you pull it up. A lot of doctors do it blindly. Some doctors directly use the duct intestine plate to push it on along the sternum of the chest mold to the neck. The doctor with the smaller hand extends the hand directly to the neck. Then it's not good to play blindly like this. This place doesn't have many vital organs. It's no problem. Generally, some bleeding is acceptable. But what is the main problem? Often breaks the mediastinal pleura, especially the left mediastinal pleura. After it is broken, you don't know where it is broken. I don't know how big it is broken. It has a problem. The tubular stomach in the thoracic position will go inside canton. Even put that blood supply to canton in it. This is such a risk. We can't accept it. Because if you put the right omentum in, that can also cause stomach necrosis. So I've been calling for it. Be sure to look straight down and drill a tunnel, because it only takes a few minutes to do the endoscopic tunneling. You can make sure that the pleura is not broken. Make sure we make this tubular stomach outside the chest cavity. Most doctors also believe that the sternum is posterior. The incidence of anastomotic leakage is higher. They think the thoracic entrance is too narrow. The bony structure is too narrow. The tube will get stuck. But actually the bony structure there will definitely be narrower, but it has a narrower upper and lower diameter. But we can trade width for height. That's what they say. That is, we can put the muscles next to us. Sternohyat muscle rips it. Rip some ribbon muscles. Make it wider. Secondly, our stomach is a hollow organ. It's not like solid organs. It's not easily oppressed. It's gas in it. It's gastric juice. So I don't think that's going to work logically either. Say that the chest is wide and the entrance is compressed, caused by a slightly higher incidence of anastomotic leakage. I don't think it's logical. So we did some research on that. For example, the patient who has been under review for a month after this surgery, we can clearly feel him coughing. A stomach bubble is getting bigger and bigger. This place looks a lot like a hernia sac. Wait, place. This is actually a gastric blister. It's the one with our tubular stomach. What's it called? Below our anastomosis. Most people believe that the blood supply is the worst. The tip of the tubular stomach. When he coughs, he feels more like coughing. There are usually such patients who leak. often coughed up. His patient will make it very clear to you. It's all coughing and bulging when you go home after surgery. These two are not missing. But he came back coughing louder and louder. There are some we are changing. For example, some miss patients swallow saliva or contrast agent. At this time, the patient often chokes and coughs violently. If it just leaks again, it will spray out. It means that the pressure inside is quite high. So why is there so much pressure? That's its anatomical basis. Because our esophagus is pulled to the anterior mediastinum. There's a corner over there. Then the thoracic entrance is a little narrow. The anastomosis happen to be in these two narrow places. Then when we cough, we will blow the air from the tubular stomach into the stomach bubble. The location of gastric vesicles at the thoracic entrance, just like our one, generates a valve. A valve that only goes in and out, so it's going to get more and more stressed. Then the anastomosis is broken. But we're also designing some now. Clinical studies to confirm our hypothesis. How to measure pressure. There are some improvements to the course. Report to everyone, my current patient. Basically, the surgery can be discharged within a week, and he ate normally when he was discharged from the hospital. I didn't put the jejunal feeding tube either. We have our set. Since you have a valve on your side, a narrow, let's pull out the gastric tube slowly. I usually take about 3 or 5 days after surgery. Do an angiography for anal exhaust. If there is no problem with the imaging, let him eat. Eating with a gastric tube for the purpose of to jam the valve. Do not form valves. That's the idea. Because of this inflatable mediastinoscopy, the recurrent laryngeal nerve has a higher proportion of hoarseness. That usually makes him eat mushy things. It's not easy to choke on mushy things. Not restricting rice paste is like a child without teeth. Paste eaten without biting function. It has eggs, meat and vegetables in it. Beat it into a wall breaker and make it into that paste. Then brush your teeth after eating. Tell him to drink some mineral water. Because the water is not afraid of choking, it will be coughed out. We do tracheoscopes and we rinse them with salt water. It's usually no problem to eat like this for 2 days. I took the tube out and went home. Go home and eat slowly. Then it's fine for half a month. Eat what you like. But tell him not to eat vegetable soup or fish soup. Eating can easily cause pneumonia. Basically, this is what we are doing now. Then I don't think there are any doctors in China who do this. I have a video recorded on the internet to teach patients how to eat. We have made a little improvement recently. It's an end-to-end anastomosis. Professor Wu Bin from Shanghai First People's Hospital told me. He said end-to-end anastomosis, make a mouth first. Then the anastomosis is done here. That's a lot of research. Just fluoresce the tubular stomach. And then I found that the part 1 squeeze had the worst blood supply. A lot of people don't either. Professor Wu Bin, he did a great job and he kind of goes backwards, and he finishes it and then knocks it out. Because if you have a tubular stomach, if you knock out the anastomosis again, you will hit the anastomosis. Or a little bit left if you don't hit it. Everyone is afraid that this little bit will break. He devised a very clever method. He told me last month that he made a dozen and they were all good. We have an improvement. Just type the reverse one and cut it open. The anastomosis is sitting in the position. Cut off the one with the worst blood supply. Here's a little video to watch. Cut it off and hit it on this one. The anastomosis hits right here, forming a nail. After finishing, just cut off these stomach bubbles with the worst blood supply. Then target the neck. There is often a gastric blister in that place after surgery. He should be much better after doing this. Secondly, we have made improvements in the past 2 months. You break the round ligaments, you let the liver hang down. The tubular stomach is a little smoother when it hangs down. Because we are going to pull behind the sternum. If you were hanging from it and being hoisted, it also seems to form a wave. One more thing. We have latissimus and subcutaneous sutures in our neck. We will now put no matter what muscle. The anterior cervical muscles are sewn together with the sternocleidomastoid muscles. Cover the weak environment. After these improvements, there have been about 20 such patients in the past. It went well without a leak. Take it out and share it with you. Then I think the current 3 combine. It's the most satisfying combination. I've been doing esophageal cancer for so many years. Minimally invasive, beautiful, and safe. And I had a hunch. Surgery options for esophageal cancer in the next 5 years. The mainstream should be an inflatable mediastinal mirror. This is a second. There must be more and more people developing post-sternal. Professor Li Yong, Professor Hu Shendong, they have a group. I'm in there too. And when it was done, it was great, and it was reassuring. At least there are no major complications. There was no such thing as an esophagotracheal fistula. What kind of pleural fluid, pneumothorax, or major vascular bleeding? Patient management is very convenient. Because there is no tubular stomach in the entire chest cavity. Many complications are due to there's a stomach inside the chest. Because the chest and stomach occupy part of the chest cavity. And when you cough, the change in pressure inside. Sometimes it's unpredictable. You can chat again in the video later.